So I would like to welcome all of you, and let's start. How to utilize the time until the day of the exam. And because this is one of the most important things. You have to smart workly rather than just keeping hard working. So what I'm asking all of you to do is 2 weeks before the day of the exam, no more knowledge. No need to take any other new papers or revising any guidelines in kind of new sources. Don't try to read from different kinds of sources in the last 2 weeks of the exam, because will be extremely confusing. Okay. Yes, thank you. Thank you. So don't try to open a door which is very difficult to be closed later. The exam is not requiring too much knowledge. It requires some basic knowledge. And how can you remember the basic knowledge, never to lose marks in the basic knowledge? Let's put a plan. Now, if I would like to ask you just to explain this point to all of you.
बंद हो गया?
दो जगहों पे आपने ऑन कर दिया, म्यूट.
Yes, all please check your mics. I close from my side. So if I asked you, what do you think the exam is aiming to test? Now you have 200 questions in the exam, equivalent to 100% of the mark. So let's say that 20% of the questions will be recalls. Okay, recalls. These recalls, like what is the success rates of McRoberts maneuver in managing of shoulder dystocia? In the room, we are 60 persons in the room, 61. Now I can say directly, look at this, exactly 90% or more than 90%. Actually, everyone in this room knows that the percent is 90%. So when you find such question in the exam, be sure then 100% of candidates will answer it correctly. Okay, it will be outside the curve of the exam. Now, on the other hand, we have around 10% of questions are extremely difficult, that no one will be able to answer them correctly. Okay, it's these questions like if you are a registrar on duty, and when you are walking in the labor ward at the doctor's room, you found one of your colleagues putting his hand inside the jacket of another one. What should you do? Nobody knows. This question, one of the recalls, nobody knows what the answer will be. You will talk to him secretly. You will inform the medical director. You will write incident report. Nobody knows. Even if you are in this situation by yourself, I don't know what I shall do in this situation. So such questions, you will waste time, effort, repeat the reading question many times, and then you will answer it incorrectly. And this is the aim of this kind of questions. So simply 10%, no one will answer them. They are there just to making you inconfident, to making you confused, and to waste time. Now, these are 30% outside the curve. All questions will be answered by all people, will be outside. All questions will not be answered by all people, will be outside. Now, the rest of questions is 70%. And this 70% is your target. Definitely is your target. I need from all of you to gain 60% out of 70% of this kind of questions. 55% is enough. 50% you may or may not pass. You may be borderline. What are these questions? The questions discussing in gynecology, endocrinology of fertility, urogyne, pre-malignant lesions. Full stop. All other things are additional. In obstetrics, management of labor and delivery, infections in pregnancy, plus one major topic like twin pregnancy, preterm labor, premature rupture of membranes. This is the obstetric and this is the gynecology questions. 60 to 70% of the mark goes to these topics. So don't miss them as much as you can. And of course, in obstetrics, emergency obstetrics, like collapse, blood transfusion, shoulder dystocia, cord prolapse, and bleedings, either antepartum or postpartum hemorrhages. Okay. Why students fail? What are the pitfalls you should avoid? Number one, the first thing is the mindset. The mindset is I am a trainee, so I have limitations in taking decisions. I should involve people with me in the management. The patient safety is number one, so I will never do anything additional to my job descriptions. For example, if I asked you if you have a case with ovarian hyperstimulation syndrome, what is the most initial step to be done if the patient is suffering from ascites, pleural effusion, and the hematocrit is 55%, I mean critical. Now, the consultant will answer like, oh, I will start low molecular weight heparin immediately, life-saving treatment. I can do taping ascites to relieve the symptoms and to improve the urine output. I will also do maybe pleural taping to relieve the dyspnea. I will do 1, 2, blah, 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 blah. Okay. Now the answer actually is high dependence unit admission. Admission, high dependence unit admission. If you can't find the admission, look forward to the multidisciplinary team management involvement. High dependence unit multidisciplinary team. It doesn't matter what are the kind of medications you would like to give the patient, because it's not your job. Simply, if you have a cesarean section and accidentally you discovered bluish bulge in the lower segment, i.e. placenta previa, undiagnosed, what would you like to do? If the consultant will say, okay, I will open it higher somehow, I will avoid any injury to the placenta before delivery the baby, and then I will try to separate it simply. If we have some bleeding, I will go for sutures in the bed, and if the bleeding is not settled, I will go for hysterectomy. This is the answer of the consultant. But the trainee will do like, I will stop the procedure and asking for my consultant to join. That's it. Exactly. Thank you. Now, there is another point I need all of you to take care of. You have to think twice about the whole situation. Now, the same question, all of you answered correctly. Inform the consultant, stop the procedure. Now, if I change the question to the cesarean section was done, or the decision for cesarean section was taken because of severe fetal distress, and then you open the tummy, you found bluish discoloration in the lower uterine segment. Now, what will be the answer? The answer will be I will do the cesarean section, I will deliver the baby, secure hemostasis, and then ask the consultant to join. Now, what are the difference between the first situation and second situation? The first situation is not emergency. It's an elective surgery. So I can wait. The second one is an emergency condition. So I will move forwardly and then stop the procedure at some point after bypass the emergency situation and reevaluate. It's exactly like if you are going to do an emergency cesarean section with rapid entry, you have a bladder injury. Bladder injury, okay? What you should do? I will mark the bladder injury, I will deliver the baby and stop the procedure because I'm going for an emergency condition. But if the same situation happened in elective case, I will call the consultant from beginning. Okay? So this is about the mindset. What is the situation and how can I manage? Always put in your mind to never to jump in your answers. Always try to be very simple. Always try to be at the baseline. You have a case, you have an ovarian mass, for example, a teenager girl with ovarian complex mass. So what is the next step in evaluation? Transvaginal ultrasound, if not transabdominal ultrasound. I know people, they are jumping to MRI. Yes, MRI is great option, fantastic option, accurate option. But you jumped for a difficult technical imaging modality, an expensive modality. A modality requires expertise to read it correctly. Why? So always keep this idea in your mind, especially if you have multiple options and all of them are correct. I have a case, especially in contraceptions and family planning. You have to follow the step ladder thinking manner. I will give you a very simple example. You have a case, she is 35 years old, no history of medical disorders or positive family history of medical illnesses. She had 2 children and she's not planning for any babies, as well as she would like to use some effective, reliable contraceptions. These are the information. Which option is ideal for her? I will ask you. Implanon is good or not? Perfect. ICD, great, one of the most effective. Yes, Implanon, ICD. So, yeah, okay. What about the OCPs? Yeah, they are fine. They are working. Okay. So what about the injections? They are great. 3 months, single injection. They will prevent pregnancy. So what would you like to choose? What would you like to choose? If you lost your compass in thinking, the step ladder requires number 1, combined oral contraceptive pills. Number 1, OCPs. If OCPs is not indicated or contraindicated, then I will move to the next step. Long-term progesterone treatment. Implant, maybe. I know very well that Mirena is not used as a contraception for exam out. I know very well that medroxyprogesterone acetate is only preserved in 2 conditions, like epilepsy, sickle cell anemia. Otherwise, I will not choose it out. So I have Implanon as an option. If the woman has any contraindication for hormonal treatments, I will go directly for ICD. Otherwise, I will not choose ICD. You got my point, everyone. The systematic approach thinking is extremely critical. Otherwise, you will find yourself choosing all options like IOCD because IOCD is great. Okay, great. Why COC is the first one, sir? Because number one, it's cheap. Number two, no intervention. Number three, most of people are familiar with the pills. Okay, so the Implanon is by minor surgery, carrying some complications like migration or missed implant. ICD mostly associated with heavy bleeding, Implanon erratic bleeding, medroxyprogesterone delayed fertility and osteoporosis. But COCs, actually, they are treating everything like dyspareunia, chronic pelvic pain, irregular cycles. Okay, so they are not only working like contraceptions, they are maybe used also to treat many associated symptoms that 90% of women suffering from at least once in their life. That's why yes, COC is UKMEC, not category. UKMEC 2 directly. UKMEC 2 is very safe. 3 is relative contraindication. 4 is absolute contraindication. So 1 and 2, it's okay. No problems. So this is very important. Now, that's why if I asked you a question, what about a teenager woman? A teenager girl, what is the ideal? Condom. Condom is great. Barrier is great. And the double method is great. What are the recommendations for double method? Barrier method and COCs. Exactly. Because the teenagers are suffering from many symptoms with their cycles that will be relieved by COCs. Exactly. So this is what I'm talking about, the mindset. Understand, follow the steps, you will not lose anything. The second problem will be like the preparation. Now we have a lot of sources to study from. I told most of you before, your own notes is your treasure. Now, my notes are great, but I wrote them myself. I know the defects, I know the points, where are they, what are the positives and negatives. And if I would like to revise the whole curriculum in 2 hours, I will be able to revise the whole curriculum in 2 hours from my notes. So your notes for yourself will be the best. The preparation requires fixation of the basic knowledge at this point, rather than trying to put more information in your brain, because you will be lost. At the 2, 3 days, 4 days before the exam, you will feel that I can't remember anything if you have multiple sources. So from now forwards, stop different sources, focus on 1 or 2 sources. Preferably, one of them will be your notes to understand. And don't try to get inside other groups like Facebook groups, like Telegram groups. They are abundant. So they may distribute your knowledge and making you more confused. Number 3, the stress. I will never say the exam is not stressful. Absolutely, it's very stressful. Okay. But there is a big difference between stress and fear. You should be stressed, yeah, but never to be afraid from the exam. Why? Because most probably If you follow the sessions very well of our course, if you understand the instructions properly, you have more information than the exams need. Okay, so trust yourself and be sure that all people who passed the exam successfully and now they are members of the college, they were not better than you. 100%, they trusted themselves, followed the instructions, and they passed. The keys are known. So don't put yourself under market stress. Now, attempting, you have to attempt similar exam situations before the real exam. What that means? It means if you have 100 questions, I would like to answer 100 questions today, just to revise, okay? You start answering the questions, 10 minutes, you have a phone call, so you answer, and then one of your children asked you to help him in something, and then for our female friends, you stop answering the questions to cook the dinner, and then they get back, and then you remember that we have a very funny series on the TV, so I need to see the show for tonight, and then I will go back to answer some questions and so on. This attitude is not considered attempt for the exam. If you would like to answer 100 questions, you have to answer them in average 2.5 hours, exactly like the real exam. You have to isolate yourself from everything around you, because this is the same situation you will be in real within few days. So take the experience. I suffered a lot because I have no effort to stay in the same seat for more than 1 hour. After that, I'm starting to have a headache, blurred vision, so I have to change the mood. I suffered because I have to keep focused for 3 hours. It's difficult. So you have to train yourself from now for this attitude. Most of candidates fail the exam because they suffered a lot in the exam, but maybe from the headache, blurred vision, nausea, stress, because it was the first time to be under adrenaline effect for a long time. So put yourself in the stress as early as possible to accommodate to the real exam. How to make it in one go? Away from the passion and the golden sentences to improve your spirit and to encourage all of you, practically wise, you have to keep training and answer as much as you can of questions, and don't just read the question and look for the answer. Try to read the explanation, because it gives you more and more ideas and broadening your mind, okay? And be sure that it's a matter of time and experience. You may pass, you may be lucky, you may be competent, you may not pass, you may be unlucky, and until now not competent enough. But be sure that when you are competent, you will pass directly, okay? So put a goal in front of your eyes. If you even not be able to finish the syllabus, it doesn't matter. Listen to me. I told you the topics, the important topics that are enough to help you to pass the exam. If you have a new TOG article paper talking about the pre-genetic testing in twin pregnancy, these kind of questions will never come because this topic is beyond MRCOG trainee. Okay, so don't be afraid. No one is able to cover everything. No one is able to cover everything. Infertility in gynecology, endocrinology, infertility, urogyne, pre-malignant lesions management, and of course some core surgical skills. In obstetrics, management of labor and delivery, infections in pregnancy, and maybe one of these topics, preterm labor and BROM, or twin pregnancies. These are the most important, small for gestational age somehow. Family planning questions are around 5 questions in the exam. They are also considered as a guaranteed questions. So even if you are not able to finish the syllabus, don't be stressed. Don't do that. Because be sure that all people around you are not be able to finish the syllabus as well. Nobody can do this. So the time management in the exam is critical. The time management. The college suggested 70 minutes for single best answers, 110 minutes for EMQs. I suggest 50 minutes for 50 questions, single best answers, 110 minutes for EMQs, 20 minutes for revision, or to just catch the most important questions or the questions which are missed during the reading. Which one to start with, EMQs or single best answers? What do you think? What do you prefer to start with? And why? You have to tell me why. Single best answers, single best answers. Everyone is matching with single best answers. Okay. If you would like to start with single best answers, you have to put, there is no option going for the single best answer seems to be more easy, and they will be finished quickly, so give more time to. Okay, I agree with you. On the other hand, EMQs are more difficult. EMQs need full mind, fresh mind. So sometimes EMQs, you should start with EMQs because you will consume some ATPs from your brain in single best answers, despite they are easy, as you said. So, okay, either you would just start with single best answers or EMQs, it doesn't matter. It's mainly related to the time management. So if you would like to start with SBAs, 50 minutes exactly. Either you finished or not, you have to move to EMQs. Okay, you have to move. Leave the single best answers and move, because sometimes you may lose many time in single best answer and then you will be in problem in EMQs. So this is my advice if you would like to start with SBAs. 50 minutes and stop SBAs. Now, I noticed that all of you are happy more with single best answers than EMQs. And this is a very dangerous sign, because single best answers sometimes very difficult, more than EMQs. Why? All answers are correct, and you have to choose the best one. This is, I think, is very difficult than EMQs. The problem in EMQs, not in the question. The problem is the question scenario is too long. So you have to read it quickly to understand and to choose the correct answer. So This is what we will do today. How to read a long scenario rapidly and correctly. Because most of scenarios are rubbish. Okay? Most of scenarios are rubbish. No informations, but they are only single keyword that may change everything. And then if you are not able to answer correctly, you may use the exclusion criteria like what we will do right now. Let's solve some important questions. Rules for solving SBAs. Now read the question. After solve the SBAs first, ensure they are done in 60 to 70 minutes. I prefer 50 minutes in the real exam, if you would like to start with. Repeated questions carefully as well. What does this means? Now, this is one of the major pitfalls. Single best answers most probably are recalls. Am I right? But please notice that some issues and some topics, if I changed the patient's age, just the patient's age, the answer will be different. If I changed the patient's PMI, the answer will be different. So the deja vu will be your enemy in SBAs. And it happened to me. I saw the question. Oh, I know it. I saw it many times before. The answer is C. Actually, it's the same scenario exactly like the recall, but it was an infertility scenario. The recall, the patient was 33. In this one, patient is 37. Thank you. The answer is completely different. With 33, I can wait with her. With 37, I have to move rapidly because her chances are markedly declined by age. That's it. So repeat reading questions, which are very easy and it seems like you are familiar with, just to check that there are no tricks. Leading word twice. Your eyes are like a scanning camera. You are not just reading the question like you are reading a story in the bedtime. It's not like this. I'm reading the question because I'm searching for one word that may lead me to the answer. Be sure that 90% of questions are carrying the keyword. Be sure of that. Trust me. If you are not be able to catch it, this is your problem. But the question is clear. By the way, one of my seniors, I failed part 2 twice, okay, in 2015. I was so disappointed. One of my seniors said, I told him, it's extremely difficult exam. He said, no, there's no difficulty at all. No question is vague. I said, impossible. All of them are vague. Then he said, you are blind. He said that directly. You are blind. You cannot see what is the question wants from you. Just keep your eyes on the keyword. Sometimes once I catch the keyword, I'm not in need to keep reading the whole question later on. I know the answer. That's it. Note down the word like next, except, best, most appropriate. What are the initial management? What is the most appropriate management? What is the best management? They are different. Believe me, they are different. In 2015 exam, page 2, the exam was, like a paper and pen, and it's not an online exam. So in page 2, patient, 30 years, heavy menstrual bleeding, examination, testing, everything No obvious pathology. She tried some medications like tranexamic acid. And what is the best management for her? Marina, I choose that. Okay. 2 papers later, I found the same question. Patient 30 years, heavy menstrual bleeding, no obvious pathology by examination and ultrasound. What is the most initial management for bleeding? I smiled. I was so naive, by the way. Now I'm so evil in exams. But previously I was so naive. So I smiled and said, oh, this is a mistake in the exam. They repeated the question. That's nice. I had the same answer for 2 questions. I will gain 2 marks by 1 effort. So I choose Marina again. Nobody knows that the first question, the best management, is Marina. Yes. But the second question, the initial management, is tranexamic acid. Okay? So keep in your eyes the sentences and specific words like except, like best, like most appropriate, like initial. These tricks are really important in single best answers. Exclusion for unknown topics. Now, if you are competent enough, if you have 5 options, you will be able easily to exclude 3, and maybe you will be confused between 2 options. Now, even if you are not trusting your answer, your risk to lose the question is markedly declined. Your chances is 50-50. Okay? So my advice is, don't ever miss any question in the exam and answer it haphazardly. Don't do that. Sometimes 1 question is needed to pass the exam. I failed twice for 1%. 1%. You know, if I failed for 10%, 15%, it's okay. If I gain 20% in the exam, I will not be sad. I will realize that I'm a loser. Okay? But for 1%, yes, believe me, I swear. And I failed part 3 for 1%. 1% is a critical mark in my life career. Okay? So it's very critical for me. So I'm not afraid from, you know, failure itself. Maybe I fail, but it's very dramatic to fail on 1%. Why? Believe me, this is maybe happen with some of you. Under the stress of the exam, difficult questions, stress, time factor, and all of these things, you may find yourself losing hope inside the exam. So I'm not able to read anymore. Yeah, this C, A, lightly. You are taking the questions lightly. Don't do that, please, because you may do very good and you may fail because people around you do much better, and you may do very bad, but people around you are losers more than you. So you will pass. Imagine that. Okay? Imagine that. This is the game. So don't lose the faith, even if you are not happy with your answers and your performance, because nobody knows. Maybe people beside you are more bad than you, so you will pass. That's it. That's it. Okay? So always keep it in your mind. When I find the exam is difficult, I'm being very happy, because it's difficult for all people. So the pass mark will be less than expected, or more people will pass. If the exam is very easy and straightforward, I'm being very anxious. This will be more obvious in part 3. Put yourself in the space of the examiner. If you are on the station, which is repeated station, straightforward scenario, and all of this stuff. Now, if the candidate does not do perfect act, I will fail him or her, because it's an easy station, straightforward, daily practice. So why he is not able to cover it completely? But on the other hand, if the station is extremely weird, difficult, first time patch in the exam, I will be very fine with the candidate. If he say anything, I will give him mark. Imagine that. Am I right? So difficult exams never makes you angry or anxious or anything like this. Difficult exams makes you more confident. Smile, try to think more. It's my chance to pass, because the competition will be difficult. So most of people will fail. So it's my chance to pass. Okay? So take it like this. Okay. Of course, SBAs, because of the same theory, because SBAs are more easy, so most of candidates will pass SBA's curve. So if you failed in SBAs, your chances to pass are really difficult. So you have to pass SBAs. How can you do that? If there is no idea about the answer, how to choose? Okay, I will answer your question right now, just after finishing this question. Okay, I will answer your query. If you have no idea about the question, how can I answer? Is it haphazardly or not? Now, let's talk about this. Number one, if you have no idea at all, the TOG article released a study for examiners in 2014 that asking examiners to avoid the subconscious bias when they are putting the questions. What are these most important bias? Number one, the examiner is trying to hide the correct answer always from the candidate. So he will put it in between the options. What does that mean? He will avoid A, B, D, E, and put it in C. He will subconsciously. They did a study, 100 questions, 70% of different kinds of examiners putting the correct answer as C, subconsciously. So this is the first option. If you don't know the answer at all, choose C. Now, if the question is asking about number or incidence or prevalence, not a scenario like this, just asking about a number, thinking the question, is it common or not? If it's common, choose the highest number in options. If it's uncommon, choose the lowest number in options. Now, I will give you a many examples in the exam. If you revise recalls, a woman had a history of shoulder dystocia. What is the risk of this woman to have another shoulder dystocia in next delivery? 2 times, 4 times, 6 times, 8 times, 10 times more. 10 times! Yeah, it's common. 10 times. It's correct. It's correct. Easily. Now, a woman with, she's premenopausal with simple cyst, simple ovarian cyst. What is the incidence of this cyst to be malignant? 1 in 1,000, 2, 3, 4, 5. Yeah, it's uncommon. It's uncommon. I will choose the least option. 1 in 1,000. Correct. Okay. Okay. Is it clear? So with numbers, just ask yourself, is it common? Go for the highest rank. If it's not, go for the least one. It's a good option rather than try to choose anything. Okay. Number 3. Again, try to minimize the mistakes. How can I do that? At least if you have a very simple logic thinking in the question, try to exclude options as much as you can. For example, this question. I'm reading this question. Valval injury. Oh, sorry, valval pathology. Examination. Okay. What are the most important points in the woman is, number 1, the woman is postmenopausal. Of course, the answer is lichen sclerosis, but why? The woman is 72. I know that all of you knows the patient is lichen sclerosis. I know. But I'm looking now to see you, what are the most important things? Postmenopausal, thinned skin, lateral fusion of the labia. Aha. This is a very characteristic finding. Thin, fusion, fibrosis, dyspareunia. Yeah, dyspareunia. It's important as well. Okay. So all of these things are considered leading words. Now, I don't know anything about the answer. Okay. I don't know anything about the answer. How can I answer this question by exclusion? Let's do this. Psoriasis, I don't know. Psoriasis, I know this disease. It's like a scales and, affecting the hair and nails. I don't think so. Out. Squamous cell carcinoma mostly will be presented by an ulcer. Out. Lichen sclerosis, I don't know. Lichen planus, I don't know. Paget disease of the vulva is, I don't know anything about the Paget. So A, B out. The answer may be C, D, E. So you minimize the risk of mistakes. Okay. The exclusion criteria is also sometimes related to the background. The background. Okay. How's that? If you would like to take a look on the 5 options, if you think more and more, you may discover that 4 options are related to each other and 1 option is outside this background. This is one of the possible ways of thinking. I'm always trying to think like this. So is there any link between all of them? I can either exclude the wrong answers. Now let's see. Squamous cell carcinoma and Paget's disease, all of them are cancerous and precancerous lesion with lichen sclerosis. I'm right? So I think it's related to something precancerous. So psoriasis is out, lichen planus is out. Squamous cell carcinoma is an ulcer, out. So I'm, confused between lichen sclerosis and Paget disease. I'm thinking with you. Maybe I'm wrong, but I'm just trying to think. I'm just trying to minimize my bad choices. So I'm confused between C and E. As a very lucky guy, I will choose E, but the answer is C. It doesn't matter, okay? But you may be more lucky and to choose C, and the true answer is C. So you can answer unknown question by, number 1, the C theory. Number 2, if numbers highest and lowest. Number 3, exclusion criteria. Number 4, different backgrounds. Sorry. This answer? I need it by exclusion criteria. Who would like to answer? Let's see the answer. D, by exclusion. Let's see. 1 centimeter. It's too small. Yeah, it's too small. So how can I do incisional biopsy from a very small lesion like this? So incisional out, AB out. Why I will do wide local excision with lymphadenectomy in suspicious lesion, out. Steroids, I can't offer steroids with suspicious lesion. I need to be sure, out. So the answer is D. By exclusion. I don't know what is the key biopsy. I don't know the technique. I don't know anything. I don't know anything, literally. I'm just going by logic. Okay, I'm just going by logic. This is 90% of the exam. Believe me, this is 90%. 75 years old, it's high risk cancer. I can't offer treatment. I have to confirm. Steroids out. The mass is 1 centimeter. I can do surface wedge biopsy and incisional biopsy. AB out. No need for lymphadenectomy, out. Okay. Sir, please, again, after this, explain where to do incisional and where to do excisional biopsy. Rabia, excisional biopsy is not in your exam, okay? Because excisional biopsy is not recommended as it may change the staging later on, okay? So incisional biopsy can be done in masses more than 1.5 centimeters. You can take a wedge from the edge. I had a case just 1 week ago. I took a wedge 0.5 centimeters multiply 0.5 centimeters. This is more than enough. But if it's less than 1.5 centimeters, it will be very difficult. So we will go for Keys biopsy, which is equivalent theoretically to incisional biopsy. Sorry, excisional biopsy. But we are taking more slightly biopsies. Yes. The answer is Keys bunch biopsy. Okay. 52 years old, had a leads for CIN3. She came with biopsy showing unclear margins. What should be the answer? Any suggestions? B, repeat the leads. B. Now look at this. Look at this. If I agree with all of you. So what if the conization, I will answer this question later. Follow up are, for me, they are query because I have a pathology which is serious, CIN3. Hysterectomy is too much aggressive for treatment CIN, out. Conization was only discussed in our syllabus in fertility preservation cancer stage 1A2. That's it. 1A1 lids can be done. 1A2 can be treated with conization, more depth excision. Okay, so most probably I will go for repeat lids. But what if I changed the patient's age from 52 to 42? Is that makes change? The answer will be C. Maria, excellent. Thank you. Now, this is what I'm talking about. This is what I'm talking about. Under 50, over 50. Under 50, no repeat excision. Follow up at 6 months. Over 50, repeat excision immediately. So what does that mean? It means the age is critical in this exam because it reflects is the woman in high risk group or low risk group, and it reflects the patient safety, which is the core point in MRCOG's trainees. When to go for hysterectomy? Hysterectomy should be done in the following situations. Menopausal or not requires fertility anymore in cases of cancers, all kinds of cancers, and only one pre-malignant lesion. Anybody knows? Pre-malignant lesion. Endometrial hyperplasia. Why? Because endometrial hyperplasia is rapidly developed. Cervical cancer takes around 10 years to be happened. Number two, it requires intervention, while following up the cervix is a very outpatient step. So we can keep following the patients, but in endometrium with pre-malignant lesions, it will be maybe difficult. So if the woman diagnosed with endometrial hyperplasia and she's, covering the points, go for hysterectomy directly. Otherwise, even in ovaries, if you are going to do with pre-malignant or borderline ovarian tumors, you will go for prophylactic oophorectomy or adenocelectomy, fallopian and ovarian removal. The uterus will not be removed. Okay, hysterectomy by name only indicated in cancers and endometrial hyperplasia, otherwise not. Okay, that's good. The answer, sorry, this is a mistake. Yeah, this is a mistake. Twice weekly. Yeah, the answer is D, twice weekly. The bar is located in the wrong way. So yes, twice weekly. This is because if you, for our friend who answered like weekly CTG, let me ask you a question. After 41 weeks, is this woman at high risk of fetal incident or not? Definitely yes. Okay, so it's very logic to over twice. It's by logic. Don't try to be more sophisticated and try to think outside the box, because the answer inside the box. This woman is at high risk. I need to keep eyes on the baby. So simply, and if you can correlate some informations together, CTG is covering 3 to 4 days maximally after doing it. So I can say that if the CTG is fine, I can guarantee that your baby will be fine for the next 72 hours. So we need to repeat it. Am I right? So it covers 72 hours. So I need to do it twice weekly, not one per week. Got my point? So even if the evil comes to your mind and said, no, one time is enough per week, you have to say, this patient is high risk, so I will do twice. This is the logic thinking away from the knowledge, if you don't know the knowledge in case. A couple presented to the fertility clinic with history of primary infertility, 13 months. I mean, 2.5 years. All the relevant investigations carried out were normal. What will be your next step in management? Okay, this question is vague. Okay, the answer, of course, is IVF. Yes, I think the problem in the presentation is the correct answer is always below the bread bar. One of the mistakes in the build-up of this one. but the answer is IVF. They are unexplained infertility. Is the woman's age makes difference in this kind of questions? I mean, in this question particularly? No, because already more than 2 years passed, okay? But if they are suffering from primary infertility for 12 months, now the question should give you the patient's age, because we may start investigations, or we can wait until 2 completed years finished. If the woman is less than 35 years, we can still waiting for 1 more year. After 35 years, I have to start investigations earlier than 2 years, okay? So infertility, endocrinology are very important. Just revise them carefully, because no one will miss these questions. So don't miss them. You know, again, the questions are related to pass or fail. They are not the difficult questions, you will answer them correctly. They are not easy questions, everyone will answer them. They are the moderate or medium difficult questions that most of UK trainees will answer them easily, because it's a part of their daily training, and you may miss them. So these questions will make difference. Of course, this is just to revise and to tell all of you that it's a copy paste from the TOG article. And then the TOG article suggested that IUI will be great, but please forget about the IUI, forget about the IUI, and again, and only think about IVF according to the NICE. No IUI in exam in unexplained infertility, despite TOG articles are suggested IUI. 34. Previously fertile male presents with azoospermia. His FSH and testosterone levels are low. What's the most likely diagnosis? B. Anabolic steroids. Anabolic steroid. Why it's not Klinefelter syndrome? Why? Because simply he was previously fertile. Thank you. So now, where is the keyword? The keyword is previously fertile. It's not related to FSH, LH, testosterone, azoospermia. It doesn't matter. Now we have a semen abnormality with previously fit one. So simply, Klinefelter, Kalman are congenital. So he will never be fit. AIS, Myroktaniski, all of these stuff are congenital genetic problems. So the only option is anabolic steroids. Exactly. Again, as usual, the bar is one option above the true one. It means we are correct. By exclusion, a woman with infertility workup showed blocked tubes with hydrosalpinx. Next step. B. Salpingectomy. I agree. Salpingectomy. Laparoscopic salpingectomy followed by IVF. Read the question. I gave the examples that are very common in the exam. The class 3 is the ovarian failure. The ovarian failure, how can I answer this question? I know ovarian failure means there is no response from the ovaries. So I'm looking for FSH, LH high. All of them are not FSH, LH high. So just A. So the A option by exclusion. It's extremely easy. Take your time. Give me your answer. Let's see. BCA. Now people are, confused. Try to follow the findings. Now most of answers goes for A. I agree. Simply, such question, too much points. Number one, the woman is hirsute. Okay, hirsutism. Menstrual periods last for 3-4 days every, so oligo or hypomenorrhea. Okay, 2 out of 3, there are no abnormalities, and this is a trick. The pelvic ultrasound shows no abnormalities, but I'm sorry, the criteria, 2003 criteria for PCO diagnosis revealed that 2 out of 3 findings are enough to diagnose PCOS. So any confirmation, can I take it as an evidence from my point of view? Yes. Testosterone level. Look at this. It's more than 2, less than 5. 2.3 is matching with PCOS. More than 2, less than 5, PCOS with hirsutism. Adrenal tumors, it should be more than 5. CAH, more than 5. Ovarian secreting tumors, more than 5. The only one in the area of 2 to 5 nanomole per liter testosterone is PCOS. Full stop. This is how can I answer and exclude other options. PCOS. The Rotterdam criteria, 2 out of 3 options or criteria. The trick here is there is no abnormalities in ultrasound. So most of people are maybe lose the correct answer. Now look at this. What do you think? Options, let's see. C, 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 D, D, C, D, tumor, C, D, C, okay. Try to think one more time. All of you thinking about these options because testosterone is above 5. Okay, it's above 5. Any other finding given to be utilized in the question? No. What about the patient's age? What about the patient's age? This age is the risk of congenital adrenal late presentation or delayed presentation is more common, or tumors? I mean, if the same scenario, a patient 50 years old, 50 years old, it's make difference? Of course, yes. So simply, with this age, I have to think about congenital adrenal hyperplasia. Okay? You have to think about this. But for higher age, you have to think about tumors, like adrenal tumors. Okay? Teenagers, you have to think about congenital adrenal hyperplasia. Now, if you revise the knowledge again, hirsutism, it doesn't matter because testosterone is already high. LH versus FSH, nowadays, it's not a parameter of diagnosis of anything. Okay, it doesn't matter. Okay, so the keyword will be testosterone higher than 5 and the patient's age. You can build up your idea about this. What is the Irish said? Be in this age. Yes, will be more in this age, Rabia. If 50, then ultrasound scan. Now, for ultrasound scan, think about this. You have many options that will not be diagnosed with ultrasound scan. The adrenal tumor will not be diagnosed by ultrasound scan. The congenital adrenal hyperplasia is a metabolic disease not diagnosed with ultrasound scan. So you will offer ultrasound scan just to, you know, exclude a certain condition with ovarian mass, which can be diagnosed by bimanual examination in 50% of patients. So cost benefit, ultrasound scan is not a good option. Am I right? This is how the British people think. This is the mindset. This is the mindset. So always think primarily about serum tests and blood tests investigations. Everyone, are you now able to think by different way about the keywords? The patient's age is one of the most important keyword in any question. If you catch it, you will answer. Am I right? That's good. Exactly. You have to think about exclusion of CAH. Okay. Now let's go to play another game with EMQs. Another strategy, another thing. Okay. The EMQs are not like the single best answers, unfortunately. The scenarios are more long, requires rapid reading, and the options are abundant. I will just tell you a very important thing in the exam. I will jump just a second, show you something. Okay. This is the list of options in EMQs. What do you think about this list? This list is, you know, in any exam EMQs, the list is divided into parts. So you will find the segment between C and E, they are mostly operative. Okay. The J to N, they are extremely advanced. The AB are very primary tumors. They are classified. In obstetrics, for example, patient pregnant 26 weeks or 28 weeks of gestation, she is here to follow up the baby. He had a history of previous IFD. Okay, this is an example. You will find the options like from A to C, amniocentesis, chordiocentesis, ultrasound guided, anything. Okay. From D to F, umbilical artery Doppler, middle cerebral artery Doppler, uterine artery Doppler. From G to I, you will find termination of pregnancy, emergency Cat 1, emergency Cat 2, cesarean section, vaginal delivery. Okay, what does that mean? Any AMQ in the exam, it's the options are classified into groups. So actually, You don't need to read the 10 options every time. You don't need to do that. Now, from the options in front of me, I know very well that A, B, they are primary stages. C to E or F, they are surgical interventions, and the others are advanced disease. So when I read the question, if it's early stage, I will just choose between A and B. Full stop. In the previous question, the woman had a history of previous IFD. This is a risk factor for SGA. I will go directly to Dopplers. Uterine, umbilical, middle cerebral. What is the gestational age? 28. So umbilical artery Doppler is the best option. I don't have to read all options every time to save the time. Just put on your eyes, primary, to read the question. Look at the options. Classify the options. You will find them like groups in sequent manner. Groups. Classify the groups. Be ready. Read the 2 or 3 questions. Every question is related to one of the sectors. Just read the options of the sectors. You will finish EMQs in 1 hour. Otherwise, people are going to read the question and then they forgot what happened in the previous sentence. So repeat the question one more time again, and then repeat the 15th options, and then they cannot take a decision. So they will go back to do like exclusion, and then you spend around 3 to 4 minutes in one question. So you will never finish this exam. And then you will cry later on and say, the exam is too long. It's not. It's related to the technique, okay? So keep the technique in front of your eyes. Now, back, just a second, back, ensure there will be around 1 to 110 minutes, 110 minutes to finish the EMQs. Don't miss reading the instructions. What is the exam looking for? Is it the best management? Is it the initial, most appropriate next step? Ideal investigation? Read the question properly. Looking again for the leading word twice. Write the same points to take care from. Practice exclusion by doing sectorization of the options. Put them in sectors. And finally, if you find some difficulties, don't be anxious, because this is the regular thing, okay? This is the regular thing. If you have 50 questions of EMQs in the paper, I need from you to answer correctly 35 to 40. This is your mission. Don't play the game that I have to answer 15 questions, 50 questions. Okay, it's not like this. Okay, now let's see. A 40-year-old woman underwent staging laparotomy due to cancer ovary. During the staging, observed both ovaries are involved. Okay, stop. Both ovaries are involved. It could be 1B. It could be 1B. Yeah, let's continue. Along with the cirrhosis of the uterus. Now I'm in advanced stage. So A, B, C, D, E, F, G, H, out. Simply. I'm looking for the last sector. And the cirrhosis of the liver. What is the stage of cancer ovary? I can see that most of you give some answers. 3C, 3L, 3C. The answer is 3C. 3C. Because it's just affecting the cirrhosis, not the liver tissue itself. If affecting the liver tissue itself, now it may be a distant metastasis, and then it will be 4B, not the parenchyma. Exactly. This question exactly took from you 20 seconds in the exam. 20 seconds. Am I right? Perfect. 20 years presents with right side ovarian mass. The tumor markers are elevated. There is a high suspicion for ovarian tumor. What would be the management plan? Aha, it means we are still exploring. So I will go for a surgery. C, D, E. These are my options. No, this is a mistake. It's C, staging laparotomy. Yes, perfect. Staging laparotomy. You are just exploring. Staging laparotomy. Unilateral salpingo-oophorectomy is out. Out. Out bilateral, unilateral, because the patient is 20 years. Even if you would like to exclude anything, you will go for the patient is still, we are discovering what's going on. So the ideal surgery is staging laparotomy. Okay. Menopause, vasomotor symptoms. Mainly the vasomotor symptoms. Put a line below vasomotor symptoms. Her past medical history includes mastectomy and chemotherapy with tamoxifen. She has come to discuss her options for menopause. She does not want to take anything unnatural or poison her body with any drug. Now, we can classify it like, look at this. The first group will be end at E. Sorry, at G. All of them are systemic hormonal treatment. Then from H to J, they are local treatments. And then the last group is phenylvaccine, clonidine, fluoxetine. They are alternative complementary treatments. What would be the answer? L, clonidine, patch, H, topical. Are we what is the treatment of vasomotor symptoms? Systemic vasomotor symptoms. HRT. I'm right? If the woman is contraindicated to take HRT or estrogen, so what is the alternative? SSRIs? SNRIs? Lena, no way to use the patch because it's also hormonal. We are using the patch if the woman had a history of, a high risk, mild to moderate risk for DVT. SNRI is if on tamoxifen. Thank you. Full stop. Straightforward. No games. No games. All of you knows there is no game in the question. It's a straightforward question. Just analyze the facts. Cancer, it's not difficult, Lena. Now say, anything hormonal is out. So all options are out except K, L, N. Clonidine is not used anymore in menopause. I said that because it works centrally on the brain, so it carries some side effects. SSRIs should not be used with tamoxifen. Fluoxetine is out. Phenylvaccine blindly. Blindly. It's not hormonal, and it's the last option. Blindly, the answer is phenylvaccine. Another question, 32. A woman with body mass index around 21 has moderate vasomotor symptoms. She does not want to take anything unnatural or poison her body. She has come to discuss her options for managing menopause. Now, the same scenario. What is the answer? What is the answer could be? N, fluoxetine. B, estrogen. Now, anything unnatural. So she is looking for natural thing. I'm right. So the natural thing will be more appropriate than any medical treatments. Finally, I have now. I need all of you to do like exactly what I did. I'm talking to myself. In the exam, I'm doing the same. I'm talking to myself. This is the game. Is there any reason for our friends who choose fluoxetine or phenylvaccine or whatever? Why? They are considered second line after HRT. Am I right? Is this woman have any contraindication to HRT? Any contraindication to receive estrogen? The ideal management? No. So why you would not like to give her estrogen? Aha, because she didn't like anything unnatural, so I can't give her estrogen. But there are phytoestrogens which are considered natural. So I can give her estrogens. In the previous scenario, I cannot choose phytoestrogens because she's a breast cancer patient. Okay, just talk to yourself. Don't read the question like you are in prison and the examiner beside you is like a soldier above in your head. Don't act like this. Take it easy. Just talk to yourself. This patient, she's look menopause, vasomotor symptoms, estrogen. Yeah, this is the rule. Any contraindication for estrogen? No. But she looks for natural thing. Okay, phytoestrogen is fine. It's that easy. That's it. Okay. They are the same question, but the criteria of the patients are different. Okay. So keep it in your mind. 18 years old, who is 1.8 meters tall with, I can see this, of 22, or BMI of 22, has normal breast development, no axillary or pubic hair. So substandard secondary sex characters. Okay. What about the cycles? I don't know. Her estrogen level is higher than the male average. Okay. But lower than female. Pregnancy test was negative. It means she's amenorrheic. Am I right? She's amenorrheic. Okay. There was a normal FSH level and markedly elevated LH. Okay, it doesn't matter. I think this is like an additional information which is not working with me. She has not yet started. That's why I translated. Pregnancy test was negative. It means the doctors asked for pregnancy test because the patient is amenorrheic. Histological analysis of tissue from recent bilateral inguinal herniorrhaphy show the presence of testicular tissue. I think it's now very easy and obvious. It's a case of AIS. Okay, testicles in the abdomen, XY indeed, but secondary sex characters goes more to the woman or a female, but they are not standard secondary sex characters. Okay, now if you would like to exclude other options, how can you always try in your training to think like this? You can build up many questions from one question. Turner syndrome. Turner syndrome is a woman. She's maybe amenorrheic, yes. 15% are menstruating, but mostly amenorrheic. But she's not tall. I'm sorry. She's very short woman. Out. Now here, 1.8. Familial delayed puberty. Nothing indicate that because there is no information about family. Out. Roktanesky syndrome. It's never Roktanesky because in Roktanesky, the girl is full secondary sex characters because she's XX and ovaries are there. Out. In Perfurthymen, there is no bluish discoloration, no bulge, no menstruation, but the woman is not menstruating here. Yes, but in Perfurthymen, there is a very important landmark, mid-cyclic regular pains. The woman had regular pain every month. So it's not here. Out. Sheehan, secondary amenorrhea. Out. Asherman, secondary amenorrhea. Out. Premature ovarian failure, normal FSH. Out. Kalman syndrome, normal FSH. Out. Polycystic ovarian syndrome. Okay. Polycystic ovarian syndrome, there is no relation to the secondary sex characters. On the other hand, the woman suffering from hirsutism, now there is no axillary and pubic hair. Out. Simply, there is no answer rather than androgen insensitivity syndrome. Even if I don't give you the testicular tissue retrieved from the surgery, okay, it doesn't matter. I can reach the diagnosis. Am I right? That's it. Sorry, 21 women had previously had regular periods and had a surgical termination of pregnancy while on holiday abroad. She developed septicemia, stop. Secondary amenorrhea, termination, then infection. 99.9%, the answer is intrauterine synechia, Asherman syndrome. That's it. This is the key word. Okay. No more effort should be done. Okay. No more effort. Gravida 2, para 1. These kind of questions is extremely important to answer them correctly. They are difficult because they are multifactorial, but you have to answer them. Gravida 2, para 1. Previous normal delivery. Prolonged labor. No pool is bulbable per abdomen. It means good engaged presenting part. Vaginal findings. Vertex at +1. It means no cesarean sections. This is how can I translate the findings. I'm talking to myself. Below 0, 0 and below, no cesarean section. Out. Left occipital anterior. Okay, normal position. Caput +2 over the occipit, maybe important, maybe not, it depends. CTG showed deep variable deceleration. There is poor pushing in spite of good contractions due to maternal exhaustion. Now I have two problems I need to deliver the baby for. Number one, deep variable decelerations. Number two, there is no good pushing. The caput is +2, so it means, what does that means? Trial of an instrumental delivery. Where? Theater or labor room? Theater or labor room? Theater. Why? Because it's mid-cavity. 0 +1 in theater. Low cavity +2 +3 labor room. Excellent. Forceps or ventouse?
Forceps.
Really,
Caput 2
yeah,
plus.
I'm really confused. Is the caput is significant or not for the ventouse? Maybe I can use the ventouse even with +2. But
Exhaustion.
with fetal distress, I have no options rather than ventouse. I mean, if the same scenario, look at this, if the same scenario and there is no caput, which one to be used? Forceps, because the baby is distressed. and the forceps chances of success are higher. So I have no time for failed instrumental trial. Got my point? Okay? So you have many options to think about, but finally try to tailor the answer according to your vision. It's very important to tailor a good answer. Please check your mics, everyone, that the mics are closed or muted. Please. Yes, thank you. Okay, that's good. Okay, this is a mistake, by the way, but no problems. Prime gravida has been in the second stage of labor for 3 hours. Stop. Prime 3 hours. Time passed. Even with epidural. Finished. Has been pushing. Okay. The head is 1/5 palpable. Okay. Vertex at +1. Right occipital posterior. With caput. Molding. CTG is reassuring. Any suggestions? Nothing urgent. Nothing urgent. Okay. Sorry. Even caput is not there. We will choose forceps. Yes, Rabia, because the baby is stressed. I said before, if you are afraid about the woman, do ventouse. If you are afraid about the baby, go for forceps. Fetal, forceps. FF. Fetal issues, forceps. Okay? Mother issues, ventouse. This is a rule. Okay? Theater. Despite there are no emergency, CTG is reassuring. +1 caput, +1 molding are insignificant. Head is at +1, but the time schedule for second stage of labor is finished. So I will go to deliver the woman in theater because we are mid-cavity using ventouse or forceps. What do you think? What do you think?
Vacuum.
Vacuum. And the better option is kiwi, rotational vacuum. Because vacuum, rotational for ventouse. Why? Because it's right occipital posterior. This is not the normal position. I'm right? In OB position, do we need to rotate? Yes. Now, the only position is normal is occipit anterior. Occipit anterior. So simply, occipit transverse or occipit posterior, they require rotation. Where? Where is the rotation? In the mid cavity. +1 or 0. If the head is at +2 or +3, I have no options rather than it's occipit anterior, so they descended successfully, or occipit posterior. It descends successfully but takes time, because occipit transverse will never exceed the excal spines below. Okay, so in +2 +3, no need for rotational instrument, but in 0 +1, I have to go for rotational instrument if it's occipit posterior or occipit transverse. Question number 7 was, the previous one is the same as Mona, it's trial in theater with forceps. Okay, so yeah. Sorry, sir, this 3 hours, is it a passive period? No, let's stop. Just to summarize it, there is no more passive and active phases of second stage. Now the second stage is 2 hours in prime gravida, maximally, 1 hour in multigravida, plus 1 hour more if epidural in place for both. So maximally, prime gravida with epidural 3 hours. Regardless the passive phase, active phase, pushing, not pushing, it doesn't matter. Okay? Previously, they are classified into passive and active. Okay, but now there is no classification, and 1 hour reduced from the total scheduled accepted time for a second stage of labor. Why not cesarean section directly? Listen to this and never to forget it. Never. There is no cesarean section in exam for a presenting part at station 0 or below. Mid cavity and below, it doesn't matter. Head 1/5 palpable. It's accepted to be engaged at level of 0 plus 1. Okay? Station 0 plus 1 plus 2 plus 3, no cesarean sections. No Neville Barnes in 0 plus 1. I need to revise this with you. No, I need to revise all these principles. Just a second. This kind of topics, of questions, you should never miss them. Just a second, please. Just a second, please. I will revise all of them. Seems like it's somehow confusing most of candidates, but yeah, just a second. Intrapartum management, best one. Again, have to go to this one. Okay. Okay. This table is the old table where there was a passive phase and active phase. Okay. What happened in the GTG is there is no more passive phase. Previously, prime gravida, for example, has 1 hour in passive phase, 2 hours maximally in pushing phase, plus or minus 1 hour more if there is epidural in place. Okay. Now there is no passive phase, so 1 hour reduced from the total time allowed. Prime gravida, if there is no epidural, 2 hours maximally in the second stage. Multigravida, 1 hour. You can add 1 hour more if the epidural is in place. I think this is clear. Okay. Now let's go to play the game of station, mode of delivery, and where. Station -1, -2. This is called high cavity, high pelvic cavity. No instrumentation in high pelvic cavity because it's markedly traumatizing. So -1, -2, cesarean section is the only option. Where? Of course, in theater. Now, mid cavity, station 0 plus 1, the site at the level of ischial spines where the head should be rotated to the correct direction and position. Occipit anterior. If the occipit is anterior, so I can use non-rotational forceps called Simpson or non-rotational ventouse. If the head is rotated, occipit posterior or occipit transverse, I have to use Kieland forceps, rotational forceps, or rotational ventouse. Kiwi. Where can I do this? Theater. High risk of failure, high risk of trauma. So I have to do it in theater. Low cavity, station +2, +3. Neville Pards forceps is the ideal one. Or ventouse. No rotation, regardless the head position. It passed, so it's okay. Okay, it passed, it's okay. So no rotation anymore. I can do it in labor room, except the primigravida at +2 with additional risk factor for failed trial. I will give you an example. Primigravida, 38 weeks. In the second stage of labor, 2 hours passed, no epidural, the woman not delivered. Okay, I have to deliver the baby. Excellent. She's primigravida at +2. Now search for another risk factor. Her PMI is 40. I will take her to the theater. 100%, because the failure rates are high. The baby is large for gestational age, and she had a previous, sorry, the baby is macrosomic or large for gestational age. I will take her to the theater. Okay. The only primigravida at +2, if additional risks are there, I will take her to the theater. Otherwise, +2, +3, multigravida, primigravida, no risks, I will deliver in labor room. And of course, Wrigley forceps for perineum, I mean outlet forceps or ventouse in the labor room to deliver the baby. This is the classification. This is how can we manage. You got my point. So I wish it's clear now for most of you. The decision when to choose. Forceps for fetal reasons. FF. Ventouse for maternal reasons. Deep variable deceleration not recovered. Forceps. Second or third degree heart failure woman, I didn't like to let her pushing more and more. I need to shorten second stage. But the baby is fine. The woman is fine. I will go for ventouse. Okay, ventouse. The forceps is more traumatizing, carrying more complications, but it's more effective and associated with higher rates of success. Okay, so I need to use the forceps in emergency conditions. Okay, very clear. That's very nice. Back again to finalize the questions. Yes. Okay. Okay. Gravida 2, the questions should be analyzed carefully. Gravida 2 para 1, normal vaginal previous delivery, diabetes on insulin. 38 weeks she was induced. Baby is large for dates. Second stage has lasted 2.5 hours and she has been pushing since was fully dilated. The CTG shows deep variable deceleration. 2/5 pool is bulbable per abdomen. Vaginal findings, vertex at +1, station at left occipitotransverse, slightly deflexed, caput +2. Wow. I like this answer. The only, despite the vertex is +1, but there are a multiple picture of obstruction, obstructed labor, obstructed labor. Okay, so the obstructed labor with large gestational age, I think the answer is perfectly cesarean section. I like your answer, all of you. It was great. Yes, C-section. The last kind of questions is related to the EMQs. Some questions related to maybe the medical legal aspects and the practice. So simply the Abortion Act, one of the most important things to be revised. And in this scenario, for example, the baby's Down syndrome, how can we, under which clause we can, what's wrong, Rabia? Why this face? Under clause E, yeah, anything related to the baby, either, no, under clause E, there is no emergency. F and G are for emergencies, okay? The emergency termination. The Down syndrome is not an emergency condition. The E, clause E, is related to any problem that may lead to permanent physical, behavioral, intellectual damage to the baby or lethal anomaly. So Down syndrome considered one of them. Others like gastroschisis, like no. C, let's revise. A, just keep it, it's very easy. A, life-threatening condition to the mother. B, a problem or a condition may lead to permanent physical or psychological damage to the mother. C, social requests and situations to the mother. D, social problems related to family of the mother. E, baby's problems. F and G for emergencies, like a woman 20 weeks or 25 weeks, 27 weeks, whatever, severe antepartum hemorrhage. The baby's living, okay? I will terminate the pregnancy. 15 weeks, pulsations are seen, baby is good, severe inevitable vaginal bleeding. I will go for curettage. I will remove this baby to save the mother. This is a kind of emergency termination of pregnancy, despite this baby is fine. Examples. A woman came to the clinic. She is a well-known patient with heart failure and pulmonary hypertension. Which clause? She is now pregnant. Which clause? A, pulmonary hypertension, she will die. Tight mitral stenosis, she will die. Marfan aortic root more than 4 centimeters, she will die. Okay? Now, a woman came to the clinic with preeclampsia, severe preeclampsia. Okay? She's 20 weeks. It's not controlled, okay, on all treatments. Termination. Huh? B. The preeclampsia is B. Now, a woman in the 12 weeks gestation, she broke up with her partner. She feels that she cannot take the responsibility alone of this baby, and she would like to terminate this pregnancy. Aha, see, so social problems related to the woman herself. Now, a woman came to the clinic. She's asking for termination of pregnancy because she had a Down syndrome baby, 5 years old. It takes a lot of effort to take care of him. D, the problem is related socially, yes, but for another people related. to the woman. Okay, so D. Okay, and E, of course. Oh, they sometimes the questions may be more sophisticated. Let's say, for example, a woman with 20 weeks, living baby, rupture of membranes. Rupture of membranes. If you would like to do termination of pregnancy, you will do it under which clause? No clause. Why? Why? I will make it more easy. E. I like this. Yes, one of the options is E. E. Or B. B is a very good option. Really, the answer is B or E. Okay, because E, the baby with very early rupture of membranes like this, baby will be 100% markedly affected. Okay, lung hypoplasia, skeletal deformities, no liquor around, all of these infections. So it could be E. Yeah. So what about B? Yes, B. If the woman catches chorioamnionitis, potentially she may have a long-term consequences like sepsis, like Asherman syndrome, like many problems. Am I right? She may have sometime, it's difficult. Yeah. Now, put in your mind, just you have to collect the puzzle. Collect the puzzle. Whom more important, the mother or the baby? The baby has no rights. The baby has no rights until he or she delivered. Okay, so the mother is more important. If I'm going to do anything, it will be for the sake of the mother's safety. So I will choose B. Just think like this. Try to collect ideas together. You got my point. Try to collect ideas. Fetal reduction, the same answer. Fetal reduction. For gender-based, impossible. No clause. A woman had 5 girls. She is now pregnant in the 6th one. She would like to terminate pregnancy because she was looking for a boy. No clause. No termination. Okay? It's a discrimination criticism. You know, Rabia, sex selection in IVF in UK NHS is a crime. It's a crime. So for termination for gender basis, no way, no clause. In one of the exams, one of the patients came asking for termination of pregnancy because her sister's wedding will be after 2 months and she will not be fitting enough, okay, to attend the wedding because her tummy will be enlarged or something like this. No clause. If you choose anything, it's unlogic. Okay, no clause. I will never terminate pregnancy, kill a baby because the dress will not be suitable for her. Okay, she can get exactly larger size dress. Okay, so sometimes the scenario is extremely odd. So no clauses. Okay, but now in fetal reduction, in IVF, multiple gestations, then fetal embryo reduction, it's done under clause B because multiple gestations carrying potential risks for difficult high-risk pregnancy for the mother. So I will do it under clause B. Sir, even if it gives stress to the mother. Yes, even if it gives stress, I can do it like C, but not for not necessarily causes. Okay. If it affects her mental health, which one? Explain more for the mental health. Anything affect physical, mental, behavioral problems should be considered. Should be considered. But please notice that in practice, if you have a woman asking for, yes, like more female babies, despite it's not negotiable point, but I will explain for you. Not all scenarios in practice, you are taking a decision and left the patient. I will take her to a counselor. If she's really affected psychologically, I will politely refuse her request, but I will never let her alone. I will involve a counselor. So regardless the answer, we have many other possible options that may be helpful for the patient. Okay. 18 years, woman requests termination of pregnancy at 8 weeks of gestation for personal reasons. Now, I think it's clear. C, yes, I agree. Let's see the question. If previous 4-5 cesarean section and then unwanted pregnancy, termination of pregnancy under clause, which clause? You have to answer this question by yourself. Just try to think a little bit more. Under clause B, previous 5 cesarean sections, accreta, percreta, blood transfusion, hysterectomy, potential risks, physical, mental, behavioral problems. Exactly, B, thank you. So this is the answer. Okay, I mean, in this question number 11, yeah, it's C, 100% it's C. 43, pulmonary hypertension. Stop reading, thank you. A, it's A. That's it. Keep reading this for 1 minute. Just read them carefully. Silence, 1 minute reading. Okay, this is more than clear and enough. We finished. No, they are the same, but no, David, they are not the same. B is elective, G in emergency. Preeclampsia is elective. But if preeclampsia with vaginal bleeding or pulmonary edema, it will be G. Okay? This is the difference. Rupture membranes is B. But if rupture membranes and the patient is feverish, so I will do under G. Okay? Yeah, perfect. I enjoyed a lot. I tried honestly to tell all of you about everything. I didn't hide anything. As usual, I'm trying to give everything I know, everything I understand, all my experience. Maybe it's a good experience, maybe it's not, but I try to do my best to make it more easy and more simple as much as I can. I wish the whole success to all of you. And I wish that we will celebrate very soon the success, and we will meet again in part 3 preparation. Thank you so much. Let's just answer these questions rapidly. Please, sir, clear 1 point. Appropriate management in postmenopausal simple hyperplasia. Hysterectomy. Ten, tererere, ten, ten. No ideas. Postmenopausal, no need for the uterus. Even simple hyperplasia. The primary management is hysterectomy. It's potential risk. Please remember a fact that even with hyperplasia, simple, 5 to 7 concomitant carcinoma are there. That's why we are going for hysterectomy. It should be tahbis, yes, 100%. Pulmonary hypertension plus pulmonary edema. For what, my friend? You mean termination of pregnancy? Pulmonary hypertension and pulmonary edema, the termination, once pulmonary edema is there, it means emergency, so it will be G. A portion close, yeah. Dear, thank you. Thank you so much again. My prayers, my best wishes. I would like to thank all of you for being with me in this session, despite stresses, despite the your commitments. I appreciate that, and I wish we will meet again in best situation, success,